Hello everyone, this is Abdullah again, and we're going to continue with the third part of the head and neck anatomy. Starting off with the parotid gland, and we need to know the surface anatomy for the parotid gland. There is a lovely photo down there from, I think this is from Gray's Anatomy. So you have here the tragus, so a point just anterior to the tragus. That's the first point that you need to mark for the surface anatomy of the parotid gland, and to another point into the center of the masseter muscle, and third point just 2 centimeter below and lateral to the angle of the mandible, and the other one is basically the center of the mastoid process. So you have here, that will be the surface anatomy of the parotid gland in this area. All right, and to continue the surface anatomy, the parotid duct is usually found at the mid third between a line from the tragus of the ear and the other point at the angle of the mouth, or it can be done in a different way. It's the middle third or the middle 5 centimeter from a line drawn between the endotracheal notch to the philtrum of the mouth. But you can note whichever you prefer. So yeah, this is the surface anatomy for the parotid gland, and it's quite an important question. Yeah, so that's the surface anatomy. We started by the head of the mandible and the front of the tragus. That's the first point. Center of the mastoid, second point. 2 centimeter below and lateral to the angle of the mandible, and center of the masseter muscle. And the parotid duct from endotracheal notch to the middle of the philtrum, and it crosses the masseter and ends by piercing the buccinator muscle opposite to the upper second molar teeth. Okay. The blood supply for the parotid gland, so as we always say, the blood supply needs to be divided into arterial and venous blood supply. If you remember in our previous dissection, we mentioned that there is an artery that passes inside the substance of the parotid gland, and that would be the external carotid artery, and you have a vein in the substance of the parotid gland that would be the retromandibular vein. So usually retromandibular vein is formed by two veins joining together. That's the maxillary vein and superficial temporal vein to form retromandibular vein. And this is in the substance of the parotid gland, and then it ends by dividing into two terminal branches. All right. So one of these branches will join the facial vein to form a branch to go to the internal jugular vein, and this one with the posterior auricular or occipital vein will form another vein, and all of them will join the internal jugular vein at the end. So you have arterial supply. It's the terminal branch from external carotid artery, and posterior auricular as well can give it, and retromandibular vein is the main vein, and it goes into the external jugular vein. Lymphatic drainage, so you are in the neck, so mainly the deep and superficial cervical lymph nodes will be the main drainage, specifically the upper one, the jugular one, and you have the deep and superficial parotid lymph nodes as well. Parotid lymph nodes are one of the drainage as well. Well, structures passing through the lymph node, we mentioned a few of them. So if you remember, we mentioned retromandibular vein, that's one, and external carotid artery, that is two. And so you have external carotid artery, retromandibular vein, and of course we do have the facial nerve as well, passing through the substance of the gland, and you have auriculotemporal nerve, again passing through the gland, and you have some deep lymph nodes, deep parotid lymph nodes will be there as well. So the way you can remember it is sphere lymph nodes. Okay, sphere lymph nodes. So sphere is the facial nerve and the external carotid artery, and the auriculotemporal nerve and retromandibular vein, and also the deep parotid lymph nodes, like we mentioned, sphere lymph nodes. Types of secretions of salivary parotid salivary gland. So generally, the salivary gland secretions can be one of two things. So the salivary gland secretions can be one of two things, whether it's a serous secretion, this is watery, or a water-rich, and a mucinous secretion, and this is generally enzyme-rich. Usually, the water secretion is the parasympathetic, and the mucinous secretion is the sympathetic supply. Okay. So the next question is asking about the differential diagnosis of a parotid lump. Like any lump, it could be one infective lump, two inflammatory lump, three is neoplastic, and four whether there is a problem in drainage of the gland. So infective, that could be such as mumps, inflammatory like Sjogren syndrome or autoimmune condition. Neoplastic, you have sort of lymphoma, pleomorphic adenoma, Warthin's tumor, and any sort of tumor, or obstruction of the duct by a stone or something like that. Sometimes you do have lymph nodes, or the deep lymph node sometimes might be enlarged, whether it's a lymphoma or Hodgkin lymphoma, things like that, or maybe metastasis to these lymph nodes. Okay, remember we mentioned the lymphatic drainage of the parotid gland is, we mentioned the deep cervical lymph nodes, superficial cervical lymph nodes, and deep and superficial parotid lymph nodes as well. Okay, parasympathetic nerve supply of the parotid gland. Before I actually answer this question, I would like to go forward and answer the nerve supply of the parotid gland. So nerve supply of the parotid gland usually takes from sympathetic, right, and parasympathetic and sensory nerve supply. So parasympathetic, it will be from otic ganglion through the auriculotemporal nerve. Sympathetic, it's from the superior cervical ganglion, and sensory from the great auricular nerve C2 and 3 on the lower half of the auricle and the angle of the mandible as well. All right. So that takes us to this nice diagram talking about the postganglionic parasympathetic supply for the salivary glands, including submandibular salivary gland, which is right there, and sublingual salivary gland, and both of them usually takes from the submandibular ganglion, right? Submandibular ganglion, which is a continuation of the chorda tympani. If you look here, this is the chorda tympani, and takes it from the fascia nerve. So you have tympanic plexus. This is the fascia nerve, continue as chorda tympani. But that's not the coverage today for. That's not going to answer our question. Our question is mainly about the parasympathetic supply of the parotid gland. So it takes from the ninth. So we're talking about otic ganglion, all right? Otic ganglion. So you need to remember the ninth. So it starts from the ninth nerve ganglion, which is the glossopharyngeal nerve ganglion. Continue with a nerve called tympanic nerve, and then tympanic plexus, and then lesser petrosal nerve. And then this is our ganglion here, otic ganglion. And then postganglionic fibers go through auriculotemplar nerve. Auriculotemplar nerve. Okay, so there is a syndrome. Okay, so we talked about the nerve supply, and we know that sympathetic and parasympathetic, and we know all the types of secretions. So sympathetic is usually mucinous in secretion, and parasympathetic is usually serous in secretion. And the great auricular nerve is responsible for sensation, including the sweat production and sensation over the parotid gland as well. Sometimes the auriculotemporal nerve is damaged, okay, and when it's damaged, it needs to regenerate. And the regeneration can happen through whether sympathetic or the sensory. So every time the postganglionic parasympathetic is stimulated, there is a stimulation of both sympathetic and sensory as well. That's why the patient get some flushing over the parotid gland, and also sweating as well. Okay, so this syndrome is called the Frey syndrome. So we know that auriculotemporal nerve supplies the postganglionic parasympathetic fibers of the parotid gland, sympathetic fibers to sweat gland as well. And damage of auriculotemporal nerve causes irregular regeneration to be causing parasympathetic fibers to switch to the sympathetic response, resulting in gustatory sweating and anticipation of eating. So next question is asking about what are the common parasympathetic nerves. It's 1973. Next is submandibular salivary gland, where the duct opens, usually in the floor of the mouth, just beside the frenulum. What are the types of secretion? It's both mucinous and serous. And we talked about the nerve supply, which is coming from the chorda tympani of the submandibular salivary gland. Okay. Nerves at risk of injury. So we talked about, so this is the gland. It has a deep and actually I can take you back to this lovely diagram. So you have, this is the submandibular salivary gland. So you have the lingual nerve, usually lingual nerve. There will be a duct. Let's say the duct will be here. So you will have the lingual nerve will be sort of coming and moving just around the duct. Okay, so this is the lingual nerve. You have the hypoglossal nerve will be sort of here between the superficial and deep part of the submandibular salivary gland. And obviously the mandible will be somewhere here. So this is the marginal mandibular nerve as well. So you have three nerves that can easily be affected, which are the lingual nerve and hypoglossal nerve and the marginal mandibular branch of the facial nerve as well. Okay, going to external carotid artery. So the external carotid artery, it usually begins as bifurcation of the common carotid artery. So you have here, this is the common carotid artery, like that. So there is a bifurcation at the level of C4 and then ascends up in the neck just to anterolateral to the internal carotid artery. So this is the internal carotid artery. So to be anterolateral to the internal carotid artery and end in the substance of the parotid gland by dividing into two terminal branches, the maxillary and the superficial temporal branch on the other side. Okay, so you look from below as well, just to specify one thing that we explained before. So you will have from here, that will be the brachiocephalic artery coming from the aortic arch, and they will give two branches as you see. This is the subclavian artery, right subclavian artery, and then the other side, this is the right common carotid artery. Remember we mentioned the thyroid gland blood supply. We mentioned superior thyroid and inferior thyroid. So this is the inferior thyroid coming from the first part of subclavian artery. So this is the subclavian artery, first part of subclavian artery there, and moving all the way up through the inferior thyroid artery like that. So this is the thyrocervical trunk. Okay, great. So we mentioned as well the superior thyroid artery. So this is the external carotid artery. So the first branch that comes from it is the superior thyroid artery. Okay. So there is another question asking about the branches of the external carotid artery. The way I prefer to classify these branches is branches from the anterior surface of the external carotid artery and the branch from the posterior surface of the external carotid artery and the branch from the medial surface of the external carotid artery and two terminal branches. So let's talk about the anterior surface. So the anterior surface will give you the superior thyroid artery, like we said, this one, superior thyroid artery, and will also give the lingual artery and the facial artery as well. So facial artery, it's the last branch from the anterior surface. It takes a tortuous course on just the lower border of the mandible, very close to the masseter here. When you try to palpate it, you will palpate it in this area, the inferior border of the mandible, just anterior to the masseter muscle, and it makes lots of collaterals and lots of anastomosis with the artery on the other side and the maxillary artery as well. Okay, two terminal branches, we mentioned them, the superficial temporal and the maxillary artery. And posterior surface, you have posterior auricular and occipital nerves. So this is occipital and this is posterior artery, sorry. This is posterior auricular and occipital. And you have ascending pharyngeal, which comes from the medial surface. You have around like 7 branches. Might sound a bit difficult to remember. However, it's easy when you classify it into anterior surface and posterior surface and medial surface and terminal branches. Okay, so there is a nerve related to the external carotid artery, which is the hypoglossal nerve. Okay, there is another question now asking about something called carotid sinus, carotid body, and carotid sinus. So carotid body is a chemoreceptor. Carotid sinus is a baroreceptor. From the name, chemoreceptor means it responds to change in the pH. So when the pH is low, so that is acidotic, it will stimulate the respiratory system to wash out carbon dioxide. The baroreceptor, baro means blood pressure or mechanoreceptors. So when there is hypotension in sepsis patients or hypovolemic shock, so the key baroreceptor will lead to production of vasoactive substance to lead to vasopression of the arteries. Okay, so these are okay. But what are the anatomical value that the carotid body is present on the upper end of the common carotid artery, just right there on the posterior aspect. Carotid sinus on the lower end of the internal carotid artery and the upper end of the common carotid artery. So these are its anatomical value or anatomical significance. All right. Well, facial artery palpation, like we said earlier, on the inferior border of the mandible, very close to the masseter muscle. So just right there. So this is for facial artery. Well, there's another artery as well on that area that will be superficial temporal artery, which is one of the two terminal branches of the external carotid artery. Obviously, this is the parotid gland, and we mentioned it early, and this is the parotid duct. Okay, great. What will happen when the facial artery is ligated? Lots of collaterals between the facial artery and the contralateral side and maxillary artery. So now we're going to cover two cranial nerves, which is the third cranial nerve and the seventh cranial nerve as well. So the course of the third cranial nerve is very important, and we're going to go through it now. So before going into detail, so obviously we have 12 cranial nerves, right? And we classify it into 2, 2, 4, 4. So 2 arise from the cerebrum, and 2 arise from the midbrain, and 4 arise from the medulla, the pons, and 4 arise from the medulla. Okay? So all of them arises from the lateral end of the medulla, except for 4 nerves, which are 3, 4, 6, and 12. The way I remember it, all of them can be divided by, can divide 12. So 12, 6, and 4, and 3, all of them arise from the midline of the brainstem. The sixth nerve, it had the longest pathway, or the longest track into the brain. And the fourth nerve had the thinnest nerve. Okay, these are quite important and relevant structures. And also, before I explain the oculomotor nerve, if we look here, so you have, this is the oculomotor nerve. Again, this is number 3, which is present in the midline. So that's oculomotor nerve. The third trochlear nerve, that's number 4. Again, it's 4, so it arises from the midline. And you have here 12, which is hypoglossal nerve. Again, if you look here, arises from the midline. Okay, and abducent nerve, which is right there. Okay, it arises from the midline. Okay, on the lateral surface, it's all the other nerves. So you have here, obviously, the salivary nuclei, which is going to facial nerve. So this is facial nerve in here, part of the salivary nucleus as well, and the glossopharyngeal nerve for nucleus ambiguous. So you have glossopharyngeal nerve in there, and you have the vagus nerve as well, all this area, and the accessory nerve, 11. All of them are lateral, and there is only one nerve that comes from the posterior surface, which is the like we said, the abducent nerve. Okay, I mean just diagrammatic in here to specify that it comes from the midline. Well, it's mainly from the posterior surface. Okay, so these are the cranial nerves. We're gonna start by the third cranial nerve and its course inside the brain. So like we said, it arises from the midbrain and it passes just between two arteries. So if you look in this diagram, we're gonna come to it now. So obviously we're looking from here. Patient is lying on bed on side and we're looking from there. So you have the internal carotid artery, that big one is the carotid artery, it's right there. This is anterior cerebral artery, and this is middle cerebral artery, and that's internal carotid artery. Okay, so on the other side, you have the basilar artery. This is the basilar artery, given the posterior cerebral artery there, and the superior cerebellar artery there. So the oculomotor nerve is this one. So it will lie between two arteries. One above, which is the posterior cerebral artery, and one below it, which is the superior cerebellar artery. Okay. This is the PCOM, or the posterior communicating artery. So it lies in there, as you can see. Again, it's quite close to the third nerve. So any aneurysm in the PCA, SCA, or PCOM will lead to compression of the third nucleus or the third cranial nerve and causing cranial nerve palsy. All right. So let's go with what's written in here. So you have it passes between the superior cerebellar artery and the posterior cerebral artery, one inferior and one superior. Okay. It pierces the dura mater and enter into the cavernous sinus, so it will be in the wall of the cavernous sinus, and then enter the superior orbital fissure and divide into superior and inferior branches. Okay, just to consolidate this, so you have a branch coming from here. It will come from the midbrain, and it will move forward. It will pass between two arteries, one above, which is the posterior cerebral artery, and one below, which is the superior cerebellar artery, and then it will continue into the cavernous sinus, and it will run inside the wall of the cavernous sinus. Okay, so inside the cavernous sinus there is the carotid artery, or the internal carotid artery. So if you have a big aneurysm of the internal carotid artery, it might even compress the nerve as well. Divide into superior branch and inferior branch, as you see here, and enter through the superior orbital fissure. So this is the course of the oculomotor nerve. Okay, so there is a question in here asking if how the PCOM aneurysm can cause third nerve palsy. So we mentioned the pathway or the course that you have a oculomotor nerve arising from the midbrain and passes between two arteries, and these are the posterior cerebral artery, and these are the posterior cerebral artery and the superior cerebellar artery. Okay, on each side, basilar artery as well, and passes forward via the lateral wall of the cavernous sinus to enter the orbit through the superior orbital fissure. The third nerve passes by the point where the PCOM artery branches off the internal carotid artery at the site of origin of the PCOM artery aneurysm. So PCOM aneurysm can lead to that. Even ICA aneurysm or PCA aneurysm, SC aneurysm can lead to compression and palsy of the nerve. But what will happen when the nerve is paralyzed? So before answering this, we need to answer the function of the nerve. Okay, so the nerve, cranial nerve, gives supply to extraocular muscle, all of them except two, which is LR6 and SO4. Superior oblique number 4 and lateral rectus takes from the sixth cranial nerve. It also gives the ciliary muscle or the molars muscle. So ciliary ganglion, which give to molars muscle, and this is responsible for pupil constriction. Okay, it also gives to the levator palpebrae superioris muscle. So what will happen when it's paralyzed? Okay, let's talk about that. So the lateral rectus is paralyzed, so the eye will not deviate. The lateral rectus is spared, and the medial rectus is paralyzed. So that will pull the eye outward. What about superior oblique? We'll pull the eye outward plus downward as well. Okay, so the eye will be pulled outward and downward. Molars muscle, the eye will be constricted or dilated, will be dilated mid-riasis due to paralysis of molars muscle, and the eyelid will have ptosis. So these are the findings that you can find in cranial nerve 3 pulse. As you can see here, it supplies LPS, superior rectus, medial rectus, and ciliary muscle, inferior oblique, and the inferior rectus. You know the paralysis will lead to outward and downward and ptosis and mydriasis, and the first 9 is mydriasis. Okay. Structures on which the cranial nerve 3 is compressed against is usually the petrous part of temporal bone, usually the attached part of the tentorium cervical. I think we can show you a diagram that can explain this a little bit. Let me find out. So here, we're going to come to this one. So here, we have number 19 and the oculomotor nerve. So it's compressed again at the attached part, which is number 5, as you can see here. So petrous part of temporal bone and the attached part of the tentorium cerebelli. I'm going to come to this diagram later on. Okay, so next one is going to be the facial nerve. We need to know the origin and the intracranial course and the branches of facial nerve. Remember, we talked about the origin early. So the facial nerve usually comes from the facial nucleus, which is that, and the facial nucleus is in the midbrain bones medulla. So I think it will be pons. So it arises from the pons. Okay, so that's the facial nucleus arises from the pons. The course, it comes out from there, and then few course, small course inside the cranium, and then enter the internal acoustic meatus to facial canal in the petrous part of temporal bone, and comes out through the stylomastoid foramen, and then enter the substance of the parotid gland, divide into multiple branches, multiple terminal branches that we're coming to them now. So the course, CP angle, then internal acoustic meatus, facial canal, stylomastoid foramen, substance of the parotid gland, and then exit. Okay, as you see here, so this is the facial nucleus. Okay, facial nucleus, that's the facial nerve in there. So very small course inside the cranium, and then enter the internal acoustic meatus, and then the facial canal. You have here the genicular body, and then we'll leave through the stylomastoid foramen, which will be sort of here. Okay. While it's inside the middle ear, it will give branch to the stapedius muscle. And this has significance, right? This has significance. As you can see, it's closely related to another nerve, which is called vestibulocochlear nerve. So any tumor or schwannoma in this area can lead to paralysis of both facial nerve and vestibulocochlear nerve, such as acoustic neuroma. All right? Well, so the branches at the end, when it comes out of the substance of the parotid gland, it will give temporal branch, digomatic branch, and then buccal branch, marginal mandibular branch, and cervical branch. As we said earlier, it gives branches to the stapedius muscle and the stylohyoid muscle and the posterior belly of digastric muscle as well. Well, so yeah, these are the branches. We talked about the nerve. It's coming from the nucleus, the facial nucleus, and then small course inside the brain, and then enter the facial canal. As you can see here, it gives the chorda tympani as well, and it comes out through the stylomastoid foramen, as you see there. Okay, while it's coming out, it gives a branch in here to the digastric muscle, the posterior pili, and the other muscle, which is the stylohyoid muscle as well. So you have here, this is the stylohyoid muscle, and the other muscle is the digastric muscle as well. Okay, posteriorly, and the facial nerve supplies those two muscles in there, and then we'll continue and then divides into 5 terminal branches. You have here, this is the temporal branch, this is the zygomatic branch, that's buccal branch, and then marginal mandibular branch, and finally this is the cervical branch in there. Okay, so these are the facial nerve and its course and branches as well. Okay, in the ear, muscle in the ear supplied by the facial nerve, we mentioned the stapedius is supplied by it. So, upper and lower motor neuron paralysis, facial nerve paralysis. So, would like to say if you have a patient face, so usually the upper, if this is the patient face, just very quickly, if that's a face, let's make it a square. The upper part, each side of the face, will have bilateral representation as upper motor neuron on both sides. Okay, so what does this mean? So usually the upper motor neuron is basically from the cerebellum or the cerebrum all the way down, so basically from the motor area all the way down to where it meets the nucleus. So this is the facial nucleus now. And then the lower motor neuron from the facial nucleus all the way down to the muscles. Okay, this is lower motor neuron. And as you see, I that's not accidental, so I drew this on one side and this is on one side. That means if this is the midline, that means there is crossing in here. However, the upper part of the face, if these muscles are upper face, the upper part of the face will have bilateral representation, like that, in the motor area. So this is, let's say, right and left. It will have bilateral representation. So what happens when you have a lower motor neuron? So it will be ipsilateral as a first instance, ipsilateral, and most importantly, upper and lower are affected. But if you have motor neuron is affected, upper motor neuron, let's say it's here. So one, it will be contralateral, and it will only be the lower part of the face because the upper part will be spared as it has bilateral representation on the motor area. Okay, so upper motor neuron, contralateral lower face, lower motor neuron is all ipsilateral face. Yeah, when you look here as well, so this is the lower motor neuron, as you see here. Okay, and when you go up to this lower motor neuron lesion, and you go up all the way up, so it doesn't have bilateral representation. It's a unilateral representation on the contralateral side, which is that color. So injury to that will lead to ipsilateral paralysis of the whole face. Basically, you have drooping of the mouth, loss of nasolabial fold, cannot raise the eyebrows, and so on. Okay. So the nucleus is divided into two halves, upper half to the upper half of the face, and lower half to the lower half of the face. Upper half supplied by the contralateral and ipsilateral motor cortex. So it has, like we said earlier, bilateral representation. Bilateral representation. Lower half of the face supplied by the contralateral side only. Therefore, upper motor neuron lesion still get ipsilateral motor cortex. And this is the explanation why the upper motor neuron is contralateral, lower face only is affected. Type of facial nerve and acoustic neuroma, that would be lower motor neuron. Acoustic neuroma patient hear louder voice on the affected side. Remember when we said the facial nerve gives a branch to the stapedius muscle? So when this is paralyzed, the muscle will be very loose and they will have wider oscillation and heightened by the reaction of auditory ossicles, and the patient will initially hear the voice louder and later on will completely lose the hearing on this side. Okay. Quickly, great auricular nerve. We mentioned it. Remember the Frey syndrome and its relation with the auriculotemporal nerve. Root value is CTN3, and area supplied is basically the angle of the mandible and the area over the parotid gland on the outer side of the ear and the outer side of the face as well, upper half of the face as well, lower half of the face, sorry, lower half of the face, parotid gland, angle of the mandible, and ear as well. Okay.